This presentation is on the therapy of infectious and parasitic disease. We're going to first just go over the basic principles of antimicrobial therapies. And there are different ways that you can break out the classification systems. This textbook that we are using this semester divides it up into a classification of susceptible organisms and the mechanism of action. So those are going to be the two principal themes in which we talk about these antimicrobials. You can decide how you like to classify them, and I like to do a cross-reference and see all the different types of ways to classify. But in our presentation, the first is microbial susceptibility to drugs, and we are going to emphasize resistance. And then the second thing is the clinical use of antimicrobials. So we'll talk about, what are the criteria for drug selection, host factors that might modify drug use, use of antimicrobial combinations, and what type of drugs we would use for prophylaxis. Okay. Before we continue, we have to be able to differentiate the terminology. The first thing is antibiotic. The second one is antimicrobial. So commonly the terms antibiotic and antimicrobial, we use them interchangeably. The textbook that you're using this semester, they're using it interchangeably. But there are some formal definitions where the words don't mean the same thing. So if we're being really strict about the terminology, an antibiotic is a chemical that's produced by one microbe, and it has the ability to harm other microbes. But under this definition, only these compounds that are actually made by microorganisms qualify as antibiotics. So drugs like the sulfa drugs, the sulfonamides, they're produced in a lab. They wouldn't be considered an antibiotic under this strict definition of antibiotic. When we use the term antimicrobial, this is defined as any drug, agent, natural or synthetic, that has the ability to kill or suppress microorganisms. So if we use this definition, there's no distinction that needs to be made between compounds produced by microbes and those that are made by chemists. So from this perspective, there's no benefit in distinguishing between drugs made by microorganisms and drugs made by someone in the lab. So when we use in our practice the terms antibiotic and antimicrobial drug interchangeably, it's not such a big deal. Okay, so as we continue with this presentation, we may use it interchangeably. You can see on this slide, this first table is breaking the classification down by susceptibility to the organism. So the way this table looks is they have classified it under narrow spectrum drugs, broad spectrum, antiviral drugs that specifically inhibit viral loads, and antifungal drugs that will prohibit fungal infections. So think about the difference now within the narrow spectrum drug classification, what types of drugs we are targeting, what type of bacteria we are targeting. So with narrow spectrum drugs, we are targeting gram-positive cocci and gram-positive bacilli. We're also going to target gram-negative aerobes and Mycobacterium tuberculosis. These are all narrow spectrum. They're going to treat only these types of microbes. The gram-positive cocci and gram-positive bacilli, we have our penicillin and our vancomycin, which are the prototypes within their classification. So use this to help you to break it down by the type of bacterium, virus, or fungus. Selective toxicity is a concept that helps us to understand that a drug can actually target a cell or organism without injuring the other cells around it or the organism within the host, right? Other organisms within the host. It's only working on the area of pathogen that it needs to destroy. So think of it in terms of, what bacteria, microbe, what fungus, and what virus it's trying to target. So with antimicrobial drugs, if we don't have selective toxicity, it could just destroy everything. It doesn't know that it's trying to just get one particular target cell or one particular target organism. It could actually harm the host as well. It could also suppress other pathogens around it that may not necessarily need to be destroyed at that point. Selective toxicity is what makes antibiotics so valuable. Without it, we wouldn't be able to treat many types of pathogens and infections. If we didn't have selective toxicity, antibiotics could even be harmful to the host because it wouldn't know to just combat or injure that target infecting organism. Okay, so if you had an antibiotic without selective toxicity, that drug would have no therapeutic utility because it would destroy our patient. So how does an antibiotic achieve selective toxicity? How can a drug that can be so highly toxic to one microbe or pathogen be harmless to the host itself? Well, really the difference lies within the cellular chemistry of mammals and microbes. And these are concepts that you probably remember learning about when you took microbiology. There are biochemical processes that are critical to microbial well-being that don't take place in mammalian cells or our cells. So drugs that selectively interfere with these unique microbial processes can cause serious injury to microorganisms, but leave us alone, leave our cells alone and intact. So this is selective toxicity. We can achieve this by making sure that they are only toxic to microbes, not harmless to the host. Okay, so we know that again, there's differences in cellular chemistry in mammals and microbes. We can target it by disrupting bacterial protein synthesis and disrupting the cell wall, or we inhibit unique enzymes of that bacteria. We can also classify drugs by classifying them and separating them by mechanism of action. Okay, so drugs either work on cell wall synthesis, cell membrane permeability, protein synthesis, lethal protein synthesis, or non-lethal synthesis of nucleic acids, antimetabolites, or they are viral enzyme inhibitors. So we're going to go through this chart and talk about each of these things. So the first thing I want to talk about are drugs that inhibit bacterial cell wall synthesis. And these are the penicillins, the cephalosporins, and vancomycin. So with bacteria, they're actually encased with a rigid cell wall. Very thick, rigid cell wall. The protoplasm within this wall are so high in concentration of the solutes, it makes osmotic pressure within the bacterium pretty high. And without it, bacteria could actually absorb water, can swell up, and then burst and cause more issues. Now, we don't have that case. Ourselves, our own mammalian cells, our human cells, we don't have this rigid cell wall. So, because of selective toxicity, these penicillins and cephalosporins, for instance, they're going to weaken the cell wall of only the bacteria and promote bacterial lysis. It will not affect us. Then we have drugs that disrupt the cell membrane. Okay, these are drugs like amphotericin B. And this will actually increase the permeability of the cell membrane, which will cause it to leak and then spill out intracellular material. So those are like the amphotericin B. We have itraconazole as another instance of this. Now we're going to talk about bacterial inhibitors of protein synthesis, like the aminoglycosides. These drugs can cause a lethal inhibition of bacterial protein synthesis. Gentamicin is an example of aminoglycoside. Aminoglycosides are the only drugs within this group that we put under the classification of bactericidal inhibitors of protein synthesis, okay, by the mechanism of action. We know that the drugs will actually kill the cell and cause cell death, but we don't really understand why inhibition of protein synthesis happens from this drug. But we also have drugs that cause non-lethal inhibition of protein synthesis as well. We have like clindamycin, for example, and tetracycline. Now, these drugs will inhibit bacterial protein synthesis, but unlike aminoglycosides, they're not going to kill the bacteria at clinically achievable concentrations. These drugs are only going to slow the growth of the microbe itself. It's just slowing it down. Now we have drugs that inhibit bacterial synthesis of DNA and RNA, or they can just disrupt DNA function. These drugs bind directly to nucleic acid by interacting with enzymes required for nucleic acid synthesis. And they could also bind with DNA and just disrupt the function of DNA. These drugs are fluoroquinolones like ciprofloxacin, metronidazole, rifampin, all because they're able to interfere with the synthesis or the integrity of the DNA and RNA of the microbe. The antimetabolites are drugs that can disrupt specific biochemical reactions, and the result is a good one. They're either going to decrease in the synthesis of essential cell constituents or synthesis of non-functional analogs of normal metabolites. They're going right for those metabolites, and that's why they're called antimetabolites. Think of trimethoprim and the sulfonamides. That's what will fall under the antimetabolites. And we know that these aren't made from microbes themselves, but in the lab. And then we have a big bunch of drugs that suppress viral replication by inhibiting the specific enzymes in your DNA. The DNA polymerase, they will also disrupt reverse transcriptase, protease, integrase, and neuraminidase. And this is required for viral replication and infectivity of the virus. So they work really well, and they're further classified under that mechanism of action. Something that I just wanted to go back and talk just a little bit more about is when we have drugs that are able to inhibit enzymes of the bacteria, like the sulfonamide drugs, which again were the antimetabolites. I just wanted to get into that just a little bit more so you can understand. They have selective toxicity because they inhibit that cell from surviving, right? So that bacteria cannot survive because sulfonamides will inhibit the enzyme that's needed to make folic acid. And these type of cells need folic acid, but not just bacterial cells need it, we also need it. But we're able to get folic acid from other places, right? And metabolize it. But for these microbes, they have to synthesize folic acid all by themselves. They can't just take up folic acid from the environment. So this is actually great because sulfonamides can help with that process or inhibit that process. Okay, so to meet the needs of the bacteria, they first have to take up PABA, P-A-B-A, which is called para-aminobenzoic acid. PABA is the precursor to folic acid, and it converts PABA into folic acid. Well, sulfonamides will block this conversion of PABA into folic acid. Without the folic acid, this bacteria cannot live. But because our cells do not need to make their own folic acid, we can get it actually from food and our diet. We are not affected by selective toxicity here, or sulfonamide toxicity to be specific. Here you can see in just a little bit more detail, the classification is just breaking down further what was in the chart. These drugs are, again, mechanism of action, inhibiting bacterial cell wall synthesis or activating enzymes that will disrupt the cell wall, promoting lysis and death. We have penicillin and cephalosporin. Ones that increase cell membrane permeability, this is amphotericin B, and they cause leakage of intracellular material. So please use the next few slides to just review and test yourselves on what was on the chart. Same thing here. We have drugs like gentamicin, which fall under lethal inhibition of bacterial protein synthesis. We have tetracyclines, non-lethal inhibition of protein synthesis. Go back and review and make sure that you understand what's on the chart and the slide. And the last couple slides here, this one is the drugs that inhibit bacterial synthesis of DNA and RNA or just disrupting DNA function. These are drugs like ciprofloxacin, which is a fluoroquinolone, metrodiazole, rifampin. And we have our antimetabolites, which disrupt specific biochemical reactions, right? This is the one that we just talked about, PABA converting to folic acid, but antimetabolites like sulfonamides can actually break this process down. And then the drugs that suppress viral replication. So these slides were just a review of the chart. But think about when we consider what antibiotic drug we're using or antibacterial drug we're using, we have to be able to distinguish between the different drugs themselves that are either bactericidal or that are bacteriostatic. What does that mean? Bactericidal drugs are directly lethal to the bacteria, okay, at clinically achievable concentrations. But bacteriostatic drugs only slow bacterial growth, but they don't cause cell death themselves. When we use a bacteriostatic drug, we're eliminating the bacteria to a point where it's actually being accomplished by host defenses like our immune system working in concert with the phagocytic cells. It's needing some help, right? Because again, we're just slowing the growth down. So we're pulling in help from the immune system. Whereas bactericidal drugs are just directly causing the breakdown of the bacteria. Make sure you understand which of these drugs are bactericidal or bacteriostatic. Antibiotics and antimicrobials are great, but we have to understand acquired resistance to antimicrobial drugs. And so in this section, we're going to look at bacterial resistance. And you've probably heard a lot about bacterial resistance, even in school when you are, learning to be a registered nurse. we're thinking about, even though we're not prescribers, we're thinking about the patient teaching involved to make sure that we are concerning ourselves with over-prescribing antibiotics or our patients using antibiotics, not finishing the course of antibiotics. These things can all contribute to bacterial resistance. And this can actually be innate, so things within us, natural and born, or they can be acquired over time. We are going to talk about here, and we're just going to limit the discussion to acquired resistance, okay? Because that has more clinical concern right now than innate resistance. And this is something you need to consider every time you prescribe an antibiotic. So, over time, the organism that you are trying to combat, and once it's highly sensitive to an antibiotic, it's going to become less susceptible. Okay, so it might lose, what this means is it might lose the sensitivity to that antibiotic a little bit or just entirely. So it's becoming resistant. In some cases, it can develop to more than one drug, and we would call that a multi-resistant drug. Acquired resistance is such a great concern in healthcare that we really have to be careful about what drugs we use. Because if we overprescribe them, or patients aren't taking them the way that they should be prescribed, the way they were meant to be prescribed, then eventually we can cause that antibiotic to be useless. Okay, so then we'd have a clinical crisis because we might need a specific agent to kill a specific microbe or infection, and we won't be able to use it because of the resistance. And then we need something else. And if science hasn't produced something else yet, then we're in trouble. So just as a rule, antibiotic resistance is associated with not only extended hospitalizations, but significant morbidity and mortality. The organisms that we're most concerned about are listed here on this slide. Okay, so some more than others. Staphylococcus aureus, we have Enterobacter species, Pseudomonas aeruginosa, the Klebsiellas. We also have C. diff and methicillin-resistant Staph aureus, which is MRSA. These are just among some of the drugs that are right now resistant to some antibiotics. Okay, so how does this resistance become acquired? Okay, the two mechanisms, spontaneous mutation or conjugation. And ultimately, all the alterations in the structure and function that we've talked about can actually be changed in the microbial genome. And there are these genetic changes that, again, can occur either from spontaneous mutation or it being acquired, acquisition of DNA from some type of external source. So the other thing is that you have to think about DNA acquisition, gaining, and this is conjugation with another bacteria. So let's first talk about spontaneous mutation. This is random. It's a random change of the DNA of that bacteria or that microbe. What are we left with? A gradual increase in resistance. And first, you might have a low-level resistance that develops first. And then after, it continues to mutate, and with additional mutations, the resistance becomes stronger. So, spontaneous mutation can confer resistance to only one drug. However, with conjugation, this is a process which extrachromosomal DNA is transferred from one bacterium to another. And to transfer this resistance by conjugation, that donor organism must have possessed at least two unique DNA segments that were coded for the mechanism of drug resistance. One that codes for the sexual apparatus required for DNA transfer, and then the other one will code again for that mechanism of drug resistance. And two of these segments together, these DNA segments, will constitute an R or resistance factor. Conjugation takes place primarily with gram-negative bacteria. Okay, so this genetic material, as it gets transferred between, the one member of the same species of bacterium, or it could be members of different species, it was going to increase resistance. But this transfer of the R factor or the resistance factor isn't species specific. It's actually possible for pathogenic bacteria to acquire R factors from normal flora in the body. So things that were not ever meant to cause our body harm, but because R factors are being transferred, it can cause an issue. And it's becoming actually more commonplace now that R factors are conjugating with normal flora. The possibility of transferring resistance from normal flora to pathogens is right now a significant concern in the clinical community. But in contrast to spontaneous mutation, conjugation frequently confers multiple drug resistance. And remember, spontaneous mutation is conferring resistance to only one drug. So what is the relationship between antibiotic use and this emergent topic of drug resistance microbes? When we use antibiotics, it will promote the emergence of drug resistance microbes. That's just how it goes. But although antibiotics promote drug resistance, they're not mutagenic, and they don't directly cause the genetic changes that underlie reduced drug sensitivity. These spontaneous mutations and conjugation, these are just random events which is independent of using a drug or not. And the drugs actually just make conditions more favorable for overgrowth of these microbes. And they may have acquired mechanisms for resistance. So if we were going to go back and answer the question, how do antibiotics promote resistance, which I do want you to be able to talk about, we have to think about two different aspects of the ecology of microbes. Microbes secrete compounds that are toxic to other microbes, and within a given ecologic location, like let's say our large intestines, maybe it's our urogenital tract, or maybe our skin, they actually will compete with each other for nutrients that are available. So let's talk about what this would look like under a drug-free condition. Various microbes in one region, they will kind of keep each other on check. And none of these organisms, they're not going to be drug resistant. But when you introduce the antibiotic, they're going to have equally detrimental effects to all of those microbes in that population. But they're not going to promote growth of any individual microbe. But if a drug-resistant organism is present, antibiotics are going to create the selection pressure, which is favoring growth by killing off sensitive organisms. The drug will eliminate the toxins. They're going to facilitate survival of the microbe that's drug resistant. And in eliminating the sensitive organs, this will actually remove competition for available nutrients. It's getting rid of the competition, making conditions even more favorable for that resistant microbe so that it can grow and flourish. Although drug resistance is not really a benefit to any organism when you think about it, especially when no antibiotics are present, because when antibiotics are introduced into the body, they create selection pressure favoring overgrowth of microbes that are resistant. Now, some agents are more likely to promote resistance than others. Broad spectrum antibiotics, they kill more competing organisms, right? Because they're broad spectrum. As opposed to our narrow spectrum drugs, they will kill less. Broad spectrum agents do actually create the most emergent situation to resistance. We're more worried about the broad spectrum agents. The more antibiotics that are used, the faster these drug resistance will emerge in our lives. Not only do antibiotics promote emergence of resistant pathogens, they actually will promote overgrowth of our normal flora. But this can also, again, be a mechanism for resistance, right? Because if they conjugate, because these drugs can increase your resistance to normal flora, and because this can actually cause our normal flora to transfer resistance to a pathogen by conjugation, we have to really make sure we're avoiding antibiotics when people do not need them. Okay, so if you don't have a bacterial infection, don't use an antibiotic. But what about healthcare associated infections? We know that in our hospital system, in our hospital sites, we use a lot of antibiotics. Resident organisms can be extremely drug resistant in healthcare settings because of all the antibiotics being used. So, healthcare associated infections are really difficult to treat. According to the CDC, the Centers for Disease Control and Prevention, 1 in every 20 patients will acquire a healthcare associated infection. And this is why it's so important to understand. There's also this term that we use called superinfection. And this is when we have a new infection that appears during the course of a treatment for something else. There was a primary infection, and now there's this new infection on top of that primary infection. The new infections will develop when we try to use antibiotics to eliminate that first primary infection. It's going to eliminate the inability to create this mechanism of action, or to undergo the mechanism of action that was intended. For instance, the antibiotics will eliminate the inhibitory influence of our normal flora, allowing the second infectious agent to flourish. So, a superinfection is a development of, let's say, for instance, the most common one I'm thinking about is when you give someone an antibiotic, maybe for a urinary tract infection, but now they develop a vaginal yeast infection. This is something that's common. The female is being treated with the broad spectrum antibiotic for UTI. Now we have a secondary infection because we have that breakdown of the normal flora. Because broad spectrum antibiotics kill more of the normal flora than narrow spectrum antibiotics, superinfections are more common in patients receiving broad spectrum agents. So, to review, not only do broad spectrum antibiotics become more important, or what am I trying to say here? Broad spectrum antibiotics will promote the most resistance and also can cause superinfections more so than the narrow spectrum antibiotics. And you can see here on this chart what drugs that we reserve for highly resistant bacteria. You don't want to just use any antibiotic again for anything. So if you have this specific highly resistant bacteria, these are the drugs that you can use. Okay, and you can see the resistant mechanism and what other alternative treatments we can get on board in case, for whatever reason, somebody is allergic or there's not that type of antibiotic available. So just as an example, vancomycin, commonly used for highly resistant Staph aureus. And it will work on the bacteria because of the thickening of the cell wall, and it becomes this altered structure of cell wall precursor molecules. With, let's see here, with the Klebsiellas, we like to use ceftriaxone, and this produces the extended spectrum B lactamases. We like carbapenems as well because it is working on the production of carbapenemase and decreased permeability. So that is how we are using this chart to help us understand what drugs are used for highly resistant bacteria.